This week, we are very pleased to have Dr. Melissa Glier and Dr. David McVea to present to us on wastewater, measuring SARS-CoV in wastewater for the purpose of surveillance in BC communities. Now, give me a moment. I just need to switch gears here. So Dr. McVea is a public health physician who recently finished his postgraduate training at the University of BC. He's now a member of the Public Health Agency of Canada's Field Epidemiology program, placed at the BC Centre for Disease Control and Environmental Health Services. In addition to the work described today, he also responds to environmental outbreaks and studies the health impacts of lead, radon, mercury, and other environmental exposures. Dr. Melissa Glier is a research associate working with Dr. Natalie Projecki at the BC CDC Public Health Lab in environmental microbiology. She is a trained molecular biologist, and her current work is focused on testing SARS-CoV-2 in wastewater to monitor transmission of COVID-19 in BC communities. She has developed and validated methods to quantify SARS-CoV-2 RNA in wastewater, and these methods are currently being used to conduct a prospective study to quantify SARS-CoV-2 in wastewater from 5 Metro Vancouver's wastewater treatment plants. These data will be used by public health as a proxy for studying COVID-19 transmission and to detect trends in COVID-19 activity. So they are going to give us a tag team presentation. We'll begin with Dr. David McVea, and then he will pass it off to Dr. Glier. So please go ahead.
Great, thank you very much for that introduction. So let's just get started. Here. Okay, so just a brief outline as we get going. So we have a couple pieces to our talk, and yes, we are going to sort of swap back and forth a little bit, and hopefully that's pretty seamless. We're going to start off talking about the occupational risk of infectious diseases for wastewater workers, and then we'll move into the presence of SARS-CoV-2 in feces and in wastewater, and whether that brings with it any occupational risk. Over to Melissa. She'll talk about development of wastewater surveillance of SARS-CoV-2 in BC. And then we'll finish up with some examples of wastewater surveillance for SARS-CoV-2 and other pathogens, how it's used in other regions. We aren't going to speak today specifically about detailed data coming from BC because those data, we're still working through them and processing them, and they're not quite ready for the public yet. But we'll talk about what we're doing and how it can be used and how it's being used in other parts of the world right now. We aim to talk for about 30-35 minutes and leave plenty of time for discussion. So water is obviously an important route for many infectious illnesses. This little cartoon here was drawn, I think, in relation specifically to Salmonella typhi, but it applies to many waterborne diseases. You can see the contaminated black, dirty water seeping out of septic tanks, and raw sewage that's running down the street and then seeping into a well area and sort of continuing that chain of transmission of waterborne illnesses. And obviously, we're lucky to know about that in this day and age, and that's why we treat water before we drink it, and we treat our wastewater before we release it back out into the environment to try and stop this chain of transmission. But because people get sick and because people use the toilet, wastewater contains pathogens. At various times, depending on what's circulating in the community, it can contain different bacteria, different viruses, different parasites, some of which are listed there. And that's just a fact that comes from the fact that wastewater is the collection point, the product of people who are shedding virus after having been infected. So this will take us to our first quick poll question, is which pathogen of the ones listed here presents the highest risk to wastewater workers?
So I will launch the poll, and here we go. So please respond, and we will show you the results once we get a good representative sample. A little more. Okay. I think I'll end it here and show you the results.
Okay. So does everybody see those?
I believe they do.
Okay, so it's pretty close between norovirus and hepatitis A. I will close this now, I think. Okay, so it was pretty close between norovirus, like I said. I guess it depends on how you define hazard and risk that we're talking about here, but it's generally recognized that hepatitis A is the most serious pathogen that wastewater workers can be exposed to. We're lucky enough in this day and age to have a vaccine for it, but it's one of the major biological risks known for the occupation of wastewater processing. Oops, sorry. I'll just take a look at this and summarize this very quickly. So the details of this review aren't too important, but what I wanted to show is that there is good evidence over the years that wastewater workers have a higher likelihood of being exposed to hepatitis A than the general population or controls working in other parts of a wastewater processing plant that aren't seeing sewage regularly. So there's a list of different studies there, and if you look off to the right, you'll see the odds ratio of having positive virology for hepatitis or evidence of having been exposed to hepatitis. So wastewater workers that are exposed to raw sewage have a 2 or 3 fold higher odds of having evidence of being exposed to hepatitis A. And it's not just GI infections either. So if you look at this study here, what they did in this study is they asked wastewater workers over a period of 1 year to document and tell whether they had symptoms of respiratory, skin, GI, or systemic illnesses. And if you look to the odds ratio column, the adjusted one is the first one there, you can see that for GI, which makes the most sense, there's about a 5-fold higher odds of those infectious symptoms. But for the other forms of infection, there's a higher odds also, although you note that those ones aren't significant. But the GI is significant, the GI symptoms. A lot of these are older studies, and we know about these exposures now. Lots of protections in place for wastewater workers, but the risk is there. Particularly for hepatitis, as I said, we're lucky to have a vaccine at this point. Now, what about the topic of our conversation today, SARS-CoV-2? Well, I mean, we all know SARS-CoV-2 as a respiratory illness, and we're talking about masking and distancing and so on, but it can be detected in feces. So up to about 2/3 of infected individuals have detectable SARS-CoV-2 in their feces. There's a fair bit of it for those who are shedding it, and it's shed for fairly long periods of time, 1 or 2 months. You can detect it in the stool. And there is a well-documented instance of SARS-1 being transmitted through sewage or through poorly maintained plumbing. So in this little cartoon here, you can see an infected individual in the bottom panel using a washroom, and then that material, that sewage, carrying infectious particles being aerosolized in some of the other buildings because the U-traps weren't properly filled with water, aerosolized into the bathrooms, and other people becoming infected. So there is documented evidence of a coronavirus like SARS being transmitted through wastewater or sewage that is contaminated. And back to SARS-CoV-2, it can persist for quite a while, as I said. And so even if your respiratory symptoms are cleared and your respiratory swab is cleared, you can continue to be shedding virus. So in these two panels, the one on the left is showing viral loads in rectal swabs. That x-axis, sorry, the y-axis is a measure of the amount of virus present. And on the right, it's the nasopharyngeal swab. And the red line is the average, and the two sets of lines are the same people. So you can see the virus is persisting in the rectal swabs for longer than in the nasopharyngeal swabs. A very important comment, though, there is very little evidence of live infectious virus. So you may be able to detect viral particles, but it's quite different to say whether these particles are complete intact virus that could infect somebody else. So in this study here, across 20 different people, you can see that each symbol represents a different body site that was sampled, and there's a number of different sites that were sampled. The one we're interested in is the downward pointing triangle feces. You can see that was detected in about half of the individuals. In some cases, more virus in the feces than in the respiratory type of swabs. But in only 2 individuals did they have live virus that was cultured. And in other studies, this has not been studied a whole lot. It's quite difficult to culture this virus, but it ranges, in very small numbers have been tested, and a small fraction or 0 of individuals have live infectious diarrhea. So to sum up this portion, I really want to emphasize that it's known that there's some biological risk to wastewater workers, but because of that, there are important protections in place. And so those are things like avoiding direct contact with sewage, reducing the aerosolization of sewage, having vaccines up to date for hepatitis. Perhaps that will extend to SARS-CoV-2 when such a virus is available, and using PPE, when necessary, boots, coveralls, gloves, and so on. And it is important to note that on average, there's less virus shed in the stool for SARS-CoV-2 than for other GI viruses, which makes sense. There is poor evidence of live virus cultured in the stool. And just using our epidemiology, there's really no strong evidence for any fecal transmission of SARS-CoV-2. So the protections that are already in place for wastewater workers are likely more than sufficient for any theoretical risk of SARS-CoV-2, and that's the conclusion of the WHO, the CDC, and so on. So we've talked now about the fact that this difficult virus that we're all battling is present in feces. The risk, thankfully, isn't too high, but nevertheless, can we make some lemonade out of that lemon and use that information for something positive? And so from there, I'm going to hand off to my colleague, Melissa.
Thanks, David. I also just want to mention that there's also been no evidence that you can culture SARS-CoV-2 from wastewater. So just one more thing to add to the fact that it's probably not a likely, it's not likely intact or alive in wastewater. It's an envelope virus, so it's a little bit less hardy. Enteric viruses are a bit more, they're a bit more hardy in the environment, so they survive for a bit longer periods of time. But what I wanted to do here is just kind of introduce the topic to you guys about the concept of using wastewater surveillance as a tool. And just want to mention that this isn't a new concept. It's been used before. Some examples with polio virus in Israel to monitor illicit drug use here in Canada and in Europe. And also my previous work was to monitor enteric viruses in wastewater, and many people have been doing that globally. So it's not a new topic, but with SARS, we're hearing about it more and more, and it's becoming something that public health is a bit more keen to to start conducting. And so the diagram on the left is just an example of different types of community that contribute to a catchment population. So eventually the wastewater is received by wastewater treatment plants. So on the top you have this community, you have a building with like a house and a community, you have community-wide facilities which include your shopping malls, hotels, events, office industry. You have hospitals, universities, prisons, and care homes. And all this wastewater from these regions go to a single wastewater treatment plant. And then for studies like ours, an autosampler is set up at the plant, and samples are collected every 24 hours at 4 degrees, and then they're sent our way for testing. And so I just want to highlight that there's many advantages of wastewater surveillance. It can provide data on changes in disease occurrence and trends in communities. Wastewater testing is also independent of healthcare seeking behaviors and access to clinical testing. So in regions that people don't have access to clinical testing or can't afford to get tested, this is a pretty good way to monitor the population. Next slide. And so there's a group in the Netherlands. They're the first group to actually report the use of wastewater for COVID-19 surveillance. And essentially, this study, they demonstrated a correlation between the SARS-CoV-2 RNA, which was detected in the wastewater, and the COVID-19 cases. And so another thing is they were able to detect SARS-CoV-2 in wastewater 6 days before the first case was reported. And so this is really exciting because this was evidence to suggest that this is a useful tool for monitoring transmission of COVID-19 in communities, and it could be an early indicator so that we could talk to public health about it and potentially mitigate the risk. Next slide. And so for our research objectives, the first objective was to optimize and develop methods for the concentration, detection, and quantification of SARS-CoV-2 RNA in wastewater samples. And I just want to mention, before the pandemic, my work was focused on detecting enteric viruses in wastewater. And so I had developed methods for monitoring enteric viruses in wastewater throughout the treatment processes. And so this was actually a really quick move for us because we already had the methods in place, and basically we just had to optimize it and utilize it for a new virus, a new emerging virus, which was a little tricky because there's a little bit more troubleshooting involved. And so once we developed these methods, the next objective was to implement these methods to conduct a prospective study to detect and quantify SARS-CoV-2 in wastewater samples for multiple wastewater treatment plants in Metro Vancouver. And so the first thing we needed to do was we needed to actually develop a method. And so just to let you know how, next slide please. And so just to let you know how the samples are collected, we have 24-hour composite raw influent samples, which is essentially raw sewage. They're collected weekly, and for about 5 months, May through September, we were doing method development. And so we were collecting samples from Annacis Island. This is located in Delta. And this this wastewater treatment is for more than 1 million residents in 14 municipalities. So it's the largest wastewater treatment plant in Vancouver, and it treats about 175 billion liters of wastewater per year. So that's quite a bit of wastewater. And so once we get the influent wastewater sample, we take about 100 mils, and we have to process it. So the whole idea here is to take a large volume and turn it into a small volume, which is microliters, so that we can do molecular testing. And so we take 100 mils, we filter it. The type of processing we do is called ultrafiltration. It's based on pore size. So it captures the virus on the membrane. And what we do is we put the sample into the filter, we centrifuge it, and then what comes out we get rid of, and then we turn the device upside down, and then we filter or spin it again. And then what comes out is actually the viral concentrate. So it's the eluate. And this is what we use. This is in microliters. This is what we use for downstream molecular applications. Next slide. And so what we do with this viral concentrate is we have to extract nucleic acids. And we do this using a robot. And it's basically using a magnetic bead silica technology. And then the two apical targets that we select are the RDRP and the E gene. And that's because this is the assay that is optimized at the BC CDC Public Health Lab. This is their COVID-19 panel that we use for the clinical cases. And how we test it is via real-time RT-qPCR. And so with that, we run standard curves that basically have these targets in them, and we can then quantify in viral copies per volume, which is per mils or liters, however you want to do it. And so this data is great, but it doesn't account for seasonality. So each wastewater treatment plant is different in that, you know, they have different inputs. They could have industrial inputs. And also depending on the region, there could be more precipitation. So we have to account for seasonality and rainfall. And so people are now using the fecal indicator. It's called the pepper mild mottle virus. Essentially, it's ingested in large quantities of people by consuming processed peppered products. And essentially, it's passed through the digestive system. And so after you digest it, it's found in the wastewater concentrations at a really high level. It's quite interesting because I actually didn't realize that people ate so many pepper concentrated products, but it's at a very high level. So we use that as our fecal indicator. So it basically tells us both the fecal input, but it also tells us a little bit about the dilution in the wastewater. So when you get dilutions from either industrial inputs or seasonal rainfall, this marker accounts for both. So it's a lot better to use this molecular marker than to use either like flow data or some other data that's collected at the wastewater treatment plant, because it's a little bit more normalized as far as it's the same molecular marker. And when you're measuring like flow data or say solids in the wastewater, you could be using different devices to be measuring those. So you want them to be consistent throughout each wastewater treatment plant and also comparable like globally or nationally. And so next slide. Having said that, our prospective study design, basically during the time that we were doing method development, we knew we wanted to use those samples for the prospective study. So I collected extra influent wastewater samples, I processed them to get the viral concentrate and froze them so that I could then use them later. So in mid-September, we started collecting from additional Metro Vancouver water treatment plants. And so now we have a total of 5. So this basically captures a larger area of Metro Vancouver. So it's not just, now I'll show the map next, but it's not just like, the Fraser regions, it's more like the all of Metro Vancouver, essentially. So we, again, are taking 24-hour composite influent samples, and we're collecting weekly for detection and quantification of the SARS-CoV-2 RNA. The total study duration is 8 months, May through September, but that's for ANASYS. The other two, obviously, we kind of started collecting for those later, and they're only 2.5 months. So next slide. This is a map showing the regional liquid wastewater system. And so the black circle is ANASYS Island. And essentially it services like Delta, New Westminster, Burnaby, White Rock, Surrey, Pitt Meadows, Coquitlam. And essentially it's kind of considered more the north and south Fraser regions. And then if you go, if you just like go left from the black circle to the yellow circle, that there is the Lulu Island wastewater treatment plant, and that one services Richmond. And then going up, you have Iona. Lots of you have probably heard of Iona or maybe gone there to look at the birds. But that one there is capturing the city of Vancouver. And then you have going up, you have North Vancouver, which is, you have Lions Gate, which is North Vancouver. And then all the way to the right is Northwest Langley wastewater treatment plant. And so that services a small portion of Langley. And so we can use this map and with access to the COVID-19 case count data, we can together monitor the trends of COVID-19 activity per region. Next slide. And so our current status is that we're collecting weekly samples from 5 major wastewater treatment plants in Metro Vancouver. We're testing for SARS-CoV-2 and the mild mottle virus for normalization, and establishing a communication plan for dissemination to the public and to colleagues in this progress. Next slide. And so this is the summary and future work. Essentially, we have developed and implemented methods for the detection of and quantification of SARS-CoV-2 in Metro Vancouver wastewater. And so this data can be used in many ways. We can detect the presence, yes, no, in community cases. You can detect trends which are increasing, decreasing, or stable in the incidence of community cases. And it also helps us understand the occupational health risk associated with SARS-CoV-2, if it's presence or absence, and potentially limits the spread of the disease in BC community. Next slide. And so our next steps is to essentially just analyze this data. We have a lot of data. We need to analyze it for all of the Metro Vancouver wastewater treatment plants. And then we also need to use exact wastewater treatment catchments to map the regional case counts and the SARS-CoV-2 quantities. And this will show a better relationship between the two. So right now, David and I are working together to get that data mapped and to show the relationships and get it ready for our presentation. And so then next we'll disseminate this knowledge to public health and to public health colleagues. Next slide. And so then I'll pass the talk back over to David.
Great, thanks very much. So as Melissa said, our data, they're not public yet. We're working through them and working on them. But some examples, there's some excellent work that's coming out of Ottawa. So I wanted to show you some examples of what they're doing there. They have an interactive dashboard. You can see on the right, there's a little drop box. This is just a static image, but online, you can change that drop box to be number of cases, change in cases, various measures of your clinical caseload. Here it is positivity, the number of people that are testing positive. and that's overlaid with the 7-day mean viral sample. So you can see the viral trends going up and down. You can see the positivity going up and down. Another way they have to look at it is to show the percent change in the rolling average. And you can see the orange line is the viral load, and you can see that bumping up quite sharply. And as Melissa said, you get a little bit of advance compared to your clinical cases, because it takes a while for people to develop symptoms, become tested, work their way through the system, and so on. So if you're looking directly at the wastewater, you can get a little bit of an advance over that. So these are some examples of what's right now available in Canada, and maybe available in BC down the road. And the next, we're a little bit behind, but I'll take a few minutes to show you a bit more of what's being developed research-wise around the world, not necessarily put into practice, but what may be coming in terms of more speculative work. So far we've talked about measuring virus in the wastewater, but not translating that back to a number of people. But if you make some assumptions, the details of this equation here aren't important, but just to recognize that if you think about how much virus people are shedding, how much wastewater they're producing, how many copies of a virus there would be in each gram of your feces and so on, you can get an estimate of how many people are infected to generate the viral load that you detect. And that's what some people are around the world are beginning to do. So I want to take you through quickly an interesting study that came out of Houston, just it's a preprint, so it's sort of hot off the press. And I'll show you what they've done with their work. It's quite interesting. The first thing they did is they showed there's a strong relationship between their calculated, or the real case counts and the viral counts. And so those are the two things on those axes. The different colors just represent different time periods, spring versus fall. But you can see that when you have a low viral load, you're seeing a low clinical case load in your catchment area for that wastewater plant. And then they show that the trend in the viral load, which is green over time is on your x-axis there, is similar in shape, but a little bit ahead of your clinical data. So there's two different ways of fitting the clinical data. One is a dark blue line and one is a light blue line through all those blue crosses. They represent your positivity rate in the community. But the dark blue one is the actual real-time rolling average. That's what you would see if you were looking at data kind of as it emerged. So you can see that the green, which is your viral load, represents that pretty well and gives you a little bit of time advance. So you can see where things are going and where they're peaking, even if you're not getting that data reflected in the community just yet. And then they created some models so that from their viral loads, they could actually calculate the positivity rate in the community. So the details of the model aren't too important, and there's two different ones they tested. What's important is the concept that you could take a viral load measured at a wastewater plant and get a fairly accurate estimate of what's happening in your community. In this case, the positivity rate, or what your clinical load of cases is. And that's different across different parts of Houston. Here are two of them, Beltway and the Bayou North. So the model gives you some different outputs, but in all the cases, it was fairly accurate. So even if you don't have clinical case information, you can get an estimate of it just from what you see in your wastewater. And you can see here it's pretty precise and accurate over time. And then as Melissa was saying, you can use that, as we're hoping to do in Vancouver, you can use that to create spatially detailed maps, because each of these little portions of Houston here is representative of one wastewater catchment area. So the maps that you see there are moving through time. Each panel is a time period, and each color represents the caseload in that region. And so you can get an estimate over time of some specific clinical outcomes or clinical aspects of the illness, even if you're not able to measure specifically what's happening. If your testing system is saturated, or if you're unable to reach a particular population for whatever reason. So in the last, you know what, I think I will stop it there. We had another example, but I'd like to leave lots of time for discussion. So I'm just going to move on to our last poll question. And this one really is a segue into our discussion. And so from what you've learned and thought about so far and heard, is wastewater surveillance of SARS-CoV-2 useful for A, B, C, or more than one of the above? Hopefully we can get the...
I'm just trying to unmute myself.
Okay.
So poll question number 4, I'm just about to launch it. There you go. And looks like we've got a clear winner here. I'll just wait for a few more. We're just shy of 70. Oh, we just hit 75. Okay, so I will end it and share the results. It's a little bit skewed.
Well, I think that's great. That's the message that we're trying to communicate, is that there's really no one purpose that is necessarily the best for this wastewater surveillance. Depending on your community and your needs, you might want to use it to detect yes or no. Is there any transmission in a small isolated community or in a large region like Metro Vancouver? Are the trends going up or down? And can we use that information to target and to guide our public health response? And so with that, I think, can we close these results? There we go. And sorry, to summarize, that SARS-CoV-2 is excreted in feces and present in stool like many pathogens. There's no clear evidence at all for fecal-oral transmission from wastewater or otherwise right now. But because of this presence in wastewater, it's possible to use this for public health responses and surveillance. And BC CDC and Metro Vancouver, along with our health authority partners, are working to develop a surveillance system for Vancouver and BC. Thank you very kindly to all of our colleagues. It's been really a team effort to get this done. In particular, we want to say thank you to Metro Vancouver, who's helped us with collecting the samples and with some of the flow data and other things that we use for this project. So,
and also, the picture on the right was my student Jo. She's the one who's been doing all of the lab work, so all of the laborious tasks, and so a special thanks to Jo. And Natalie Price-Lajecki, who is our mentor.
So any questions down the road, please feel free to let us know, and then we're happy to take any questions that are floating around in your minds.